تايم نبدأ. السلام عليكم ورحمة الله. مساكم الله بالخير جميعا. Welcome all in this webinar with cooperation between Saudi Association in Clinical Chemistry and Point of Care Testing Association and Roche Diagnostics. This is Saeed Al-Rashdi, Consultant Clinical Lab Scientist, Head of the Phlebotomy Specimen Processing, Send Out, and Point of Care Testing. Tonight I will be the moderator. Our CEO tonight is about the diabetes mellitus. Our first topic will be the current challenge in diabetes mellitus, diagnosis and monitoring. Will be presented by Dr. Abdelghani Al-Sayed. Dr. Abdelghani is Consultant Internal Medicine, Endocrinology and Diabetes, Head of Diabetes Division in Prince Sultan Military Medical City in Riyadh. Welcome, Dr. Abdelghani.
Assalamu alaikum. Good evening, everybody, and thank you for the invitation and presenting me. I'd like to thank the Saudi Society of Clinical Chemistry for giving me this opportunity to present with you here. So I hope the slide is okay. So my topic today about current challenges in diabetes mellitus, diagnosis and monitoring. So let's start with this slide about the definition of diabetes mellitus, and this is taken from the American Diabetes Association guideline. So diabetes mellitus is a group of metabolic disease characterized by hyperglycemia resulting from defects in insulin secretion, insulin action, or both. So from this definition, where are this criteria or this number of diabetes? So these are the American Diabetes Association criteria. And if you can find here, there is a fasting blood sugar of 126 and the 2-hour post-oral GTT of 200 and hemoglobin A1C of more than or equal 6.5 or blood sugar more than 200 with symptoms of hyperglycemia. So the only mention of hyperglycemia which go with the definition is only on the fourth point. So where did we get this number 126, 200, or 6.5? So I'll go through. I mean, in this lecture, through the history of diabetes, till we come out with these numbers. So the diabetes mellitus is a chronic disease. And unfortunately, diabetes mellitus is associated with micro and macrovascular complication. The main cause of morbidity in diabetes is the microvascular complication. So through retinopathy, this is the leading cause of blindness worldwide. Through nephropathy, it is the leading cause why people go to dialysis in our country and worldwide also, with hypertension. And if we find the neuropathy, it contributes mainly to limb amputation. And just there are like every 20 seconds there's a limb which is amputated due to diabetes worldwide. So these are the morbidity of diabetes. But diabetes can cause macrovascular complications, which are the cause of mortality, which is like a stroke or cardiovascular disease or peripheral artery disease. So when we treat patients with diabetes, we aim to prevent the microvascular complication, so we prevent the disability, but we aim also to prolong life expectancy by preventing the macrovascular complication. So this is the main aim in managing any patient with diabetes mellitus. From history, the first description of diabetes came from Egyptian manuscript 1500 BC, and it was written in the manuscript, too great emptying of urine. That means the patient is getting polyuria. But the first time to describe the word diabetes, It was done in 250 BC by Apollonius of Memphis, where he coined the name diabetes, meaning to go through or siphon. He understood that the disease drained more fluid than a person could consume. That mainly it means polyuria or excessive urination. The word mellitus, it came from Latin and was added to diabetes, and it means honey. So it means that the person who is producing a lot of urine, which is sweet. From the ancient Indian literature, there is, the Hindu healer, they wrote that the flies and ants, they were attracted to urine of people with mysterious disease that cause intense thirst, enormous urine output, and wasting away of the body. And they call it honey urine because they were attracted to the urine. And just if we go also to the medical literature, like in the 14th century, a physician called Willis, who's a British physician, used to taste the urine of his patient to know that they are diabetic, and it's all the time just this is honeyed urine, which is really very, very weird and very strange practice, but it was used to diagnose diabetes. That means even the diagnosis was challenging over years. So the first time to document excess sugar in the blood, it was done by John Rollo in 1798. He documented excess of sugar in blood and urine. And it takes time till 1960s when this pharmaceutical company called Ames Diagnostic, they start producing urine strip and automated measurement of blood glucose through glucometer. So where is the diagnostic criteria from all of this one? Actually, the NIH, they discovered that before 1979, there was like at least 6 sets of criteria to diagnose diabetes. So there was no unifying criteria to diagnose diabetes. So the NIH formed a group called National Diabetes Data Group, and they formed a criteria, and they circulate the criteria to the British Diabetic Association, Australian Diabetes Society, and the European Association for a Study of Diabetes. So they put these criteria as fasting plasma glucose of more than or equal 140 milligram per deciliter, which is like equal 7.8 millimole per liter, or the 2-hour value of blood sugar after ingestion of 75 gram glucose, more than 200 milligram per deciliter, which is more than 11. So these are the first unified criteria. And I do remember when I was studying in the university, we were using these criteria in 90s as a diagnostic criteria to diagnose diabetes. So from where they get this number, they get it from retinopathy data. And why they choose retinopathy data? Retinopathy is a duration dependent. So they choose the 3 prospective study. This group, the NDDG, they choose the 3 prospective study, and a total of 1,213 patients. These patients, they get oral GTT, and they were followed up for 3 to 8 years. Only 77 patients, they developed retinopathy, and these 77 patients, they were like the first people to set a criteria for diabetes, which is a fasting blood sugar more than 140, and the 2-hour post 75 gram oral GTT of more than 200. The drawback of that one, it was a small number, and these 77, just people, we don't know what was their glycemic control from the oral GTT till till they develop retinopathy. But just that criteria was sustained till 1997. So it was like almost more than 25 years till the American Diabetes Association, they formed an expert committee. And that expert committee has changed the fasting blood sugar to 126 instead of being 140 milligram per deciliter. And this is when they said that 126 gave the same prevalence or equivalent prevalence to 2-hour postprandial, to 2-hour value of more than 200 milligram on oral GTT. And when they said the fasting blood sugar more than 126, they took also again they got like retinopathy data from different population with larger cohort. So they were having almost 4,000 individuals, and it was like 5% of them they developed retinopathy at 126, and that's why it was taken as a set of criteria for diagnosis of diabetes mellitus. So since 1997, there was a change of the fasting blood sugar from 140 and it was lowered to 126 or more. But if we look here, where are the diabetes complications from this hyperglycemia? So there was we have to link the hyperglycemia to diabetes complication. So I will discuss 2 landmark trials, one done on type 1 diabetes, which is DCCT, and the other one is UKBDS done on type 2 diabetes. So I will start with DCCT. It was published in 1993 in in the New England Journal of Medicine. It was called the Diabetes Control and Complication Trial. So they took a total of 1,441 patients with type 1 diabetes. Almost half of them, they were having no retinopathy, and the other half, they were having mild retinopathy. So they took a group. One is the primary prevention cohort, and the other one is the secondary prevention cohort. They randomized this patient to either intensive therapy with using like insulin pump or multiple doses of insulin by having 3 or more daily injection of insulin, or conventional therapy with 1 or 2 daily insulin injection. The patients were followed up for a mean duration of follow-up of 6.5 years, and the primary endpoint is appearance and the progression of retinopathy and other diabetes complications like albuminuria. So the beauty of DCCT, they use 7 measurements. So they used to check the blood sugar at least 7 times a day. So they used to monitor the blood sugar before and 90 minutes after each of the 3 major meals and at bedtimes. And then they used to do hemoglobin A1C once every 3 months. And then they plot the blood sugar versus the hemoglobin A1C. So this is the DCCT result. It showed that the one in the intensive therapy arm, they were having a lower hemoglobin A1C and lower capillary blood sugar. It was 7 to 9. And when they plot the blood sugar versus the hemoglobin A1C, there was a direct relationship between the hemoglobin A1C and the blood sugar reading and the mean blood sugar. So as the hemoglobin A1C is lower, the blood sugar were lower, and as the blood sugar get high, the hemoglobin A1C was high. So there was a linear or direct relationship between hemoglobin A1C and the blood sugar monitoring. The main result of DCCT showed those with tight glycemic control in the intensive therapy arm, they get significantly lower retinopathy, and they were also having reduced albuminuria with statistically significant p-value. So for the first time, the one who get a blood sugar which is controlled, and they use the surrogate marker of hyperglycemia, hemoglobin A1C, it correlates with the diabetes complication. So the one who's having lower hemoglobin A1C, they get lower diabetes complication, mainly microvascular complication, retinopathy, and albuminuria. And because it was difficult really to measure the neuropathy. And after the era of DCCT, people start to use the hemoglobin A1C assay that is DCCT standard. So the DCCT has just formed a new era of assay for hemoglobin A1C, and if you might have this experience more than us as a clinician, they will say that this is DCCT standard. Subsequent studies using CGM plotted against hemoglobin A1C, it showed the same relationship, that there is a direct relationship between hemoglobin A1C and the blood sugar monitoring. So if the patient or the person having low sugar, the hemoglobin A1C will be low. If the person gets high sugar, the hemoglobin A1C is high. So there is a direct relationship between the blood sugar and hemoglobin A1C. Sorry. So for the second landmark trial, which is UKBDS, and this is the landmark trial which was done on type 2 diabetes patient. So this is also done in the last century, done on more than 5,000 patients, newly diagnosed type 2 diabetes. They were either randomized to conventional therapy group versus intensive therapy. So they ran the trial for 20 years. The difference in hemoglobin A1C between the two group was 7 versus 7.9 in the conventional group, with a median follow-up of 10 years. So they used the sulfonylurea and insulin therapy in the intensive therapy arm. The main result that it showed that by reducing the glucose exposure, hemoglobin A1C 7 versus 7.9 over a median period of 10 years with sulfonylurea or insulin therapy, they get a result of reduced risk of any diabetes-related endpoint, and they mean by endpoint is the diabetes complication, by 12%, a reduction of microvascular disease, which was really significant, by 25%, and 16% reduction, our trend in reduced risk of myocardial infarction. It was barely positive, p-value with 0.052, but on a follow-up trial after 10 years, it was positive. So the main lesson from UKBDS, with each 1% reduction of hemoglobin A1C, we get a reduction in death-related diabetes by 20%, a reduction in microvascular complication by 37%, and a reduction of myocardial infarction by 14%. So what was the implications of DCCT and UKBDS? Both of them showed there is a clear relationship between the hemoglobin A1C and diabetes complication. So if you get a tightly controlled blood sugar with lower hemoglobin A1C, the patient get lower complication, and as the hemoglobin A1C increased, the diabetes complication increased. In 2010, there was a new era also done by the American Diabetes Association, where they add a new criteria for diagnosis of diabetes. So they use the cutoff value of hemoglobin A1C of 6.5, equal or more than 6.5, to be a diagnostic criteria for diabetes. This cutoff value was taken because they could identify 1/3 fewer individual than a fasting plasma glucose cutoff value more than 126. Although we don't see it in our community, we could see more patients with hemoglobin A1C if we do hemoglobin A1C than doing the fasting blood sugar. But even when they used the hemoglobin A1C of 6.5, they were looking to a retinopathy data driven from Egyptian plus Australian group, and they took the value of 6.5% as a cutoff value for diagnosis of diabetes. So the rationale of recommendation of hemoglobin A1C was that that hemoglobin A1C give an average blood sugar control and correlate with diabetes complications, so it should be used as a diagnostic criteria for diabetes. But you have to be careful that hemoglobin A1C is a surrogate marker of hyperglycemia rather than the measuring the blood sugar, which is high or wrong. And they stated if you use the hemoglobin A1C as a diagnostic criteria, it has to be NGSP standardized. So the assay has to be standardized through the National Glycohemoglobin Standardization Program. So this is the final criteria. So since 2010 till 2021, it is the same criteria. The fasting blood sugar more than 140, the 2-hour post-oral GTT more than 200, the hemoglobin A1C more than or equal 6.5, or a person who get symptoms of hyperglycemia with blood sugar more than 200. And after a year of setting the diagnosis of hemoglobin A1C of 6.5, there was a lot of debate. The European refused that criteria. So it came up with this debate in 2011, and it was published by this person who's David Sachs, who's a clinical biochemist. A1C versus glucose testing as a comparison. And in his paper, he stated the advantage and disadvantage of each test. So he said the fasting plasma glucose advantage is the glucose assays is easily automated, widely available, it is inexpensive, and single sample. The problem with using the fasting plasma glucose as a diagnostic criteria for diabetes, you should tell your patient to fast for 8 hours. It has large biological variability, so if you do it in 2 consecutive days for the same person, you might get like different values. One is normal, the other one is abnormal. It has diurnal variation related to hormones. Concentration varies with the source of samples, whether venous, capillary, or arterial blood. Fasting plasma glucose less tightly linked to diabetes complication. So the study, when they saw the diabetes complication, it was strongly associated with hemoglobin A1C in a linear relationship, and it mainly reflects the glucose homeostasis at a single point in time. And there is a problem also with the fasting plasma glucose is the glycolysis. So we know there is the test tube of glucose. It contains some material that inhibit the glycolysis, but this one only stands for 2 hours, and the glucose concentration decrease in the test tube by 5 to 7% per hour due to glycolysis. On regard to oral GTT for diagnosis of diabetes, the advantage, it is sensitive indicator of risk developing diabetes. By the way, the oral GTT is still the gold standard for the gold standard test for diagnosis of diabetes, and it is an early marker of impaired glucose homeostasis, because you just give a load of glucose and you check the blood sugar as fasting plus 2 hours after loading with the glucose. The disadvantage, it lacks reproducibility, extensive patient preparation, so the patient has to come early morning fasting, and then they check the blood sugar, take the 75-gram oral glucose, and then wait for 2 hours. So it's time consuming and inconvenient for some patient. It is I mean, to a lesser extent, it's expensive and influenced by numerous medication, and it's subject to the same limitation like fasting plasma glucose. Mainly, it's not stable and need to be performed in the morning. So, on regard to hemoglobin A1C, hemoglobin A1C, it can give you falsely high level, especially in any condition where there is red blood cell survival, it increase, like in iron deficiency anemia, or even iron insufficiency, vitamin B12 deficiency, or insufficiency, or folate deficiency. I came across this reference, which showed that in person with iron deficiency anemia, they can have inappropriately rise of hemoglobin A1C by 1 to 1.5%, which fall after iron treatment. That means if your patient is having iron deficiency anemia and some other even insufficiency, and there is no really clear definition of insufficiency, it can give a rise of a falsely rise of hemoglobin A1C by 1 to 1.5. So 1.5, that means if the hemoglobin A1C is 6.5, it could be 5 or it could be 6.5, which means that it's either normal or the patient is having diabetes. So I think we need to be careful. I've seen patients with falsely high hemoglobin A1C to an extent of 6.7, and they have totally normal blood sugar. So you have to know the limitation of the hemoglobin A1C test, especially in your population. The falsely low hemoglobin A1C, so anything which reduce the survival of red blood cell, or you get more young red blood cell in the system, it will lead to falsely low hemoglobin A1C, like hemolysis, or those are treated with iron or vitamin B12 or folate supplements, or a person who's treated with erythropoietin. And we have to know also that the hemoglobin A1C can increase by 0.1% every decade. So hemoglobin A1C, if you use it for diagnosis, it has to be NGSP standard. So what is NGSP? It's the National Glycoprotein Standardization Program. It is done by DCCT investigator, and the purpose of NGSP is to standardize hemoglobin A1C test result to those of DCCT and UKPDS. And it was mainly done because, there was a deficiency of DCCT samples or standardized assay. So there was a need for another method to standardize the hemoglobin A1C to the same DCCT, and that's why I came up with NGSP program. And there is another one called IFCC, which is recently, since a few years, it was applied. This is the International Federation of Clinical Chemistry and Laboratory Medicine. They get a reference of hemoglobin A1C in a wider range in millimole per mole, and this is like the table of conversion of NGSP hemoglobin A1C in percentage to IFCC millimole per mole, and there is also just a calculator. You can apply the calculator to calculate the conversion of hemoglobin A1C from percentage to IFCC, or the reverse. There are other traditional biomarker of hyperglycemia like fructosamine or glycated albumin. So these are glycated protein, and they reflect the hyperglycemia over 2 to 3 weeks. Previously, they were widely used, but for the time being, their use is mainly just in the investigational lab. So in management of diabetes, we have the diabetes self-management program. So we use the self-monitoring of blood sugar, and we find a problem. There is something called glucose variability, which can predict the risk of hypoglycemia. And this is one of the limitation of hemoglobin A1C. It cannot really predict the variability. So you might have two blood sugar monitoring, one with high variability, the other one with low variability, and both of them, they get the same mean of hemoglobin A1C of 6.8, which is excellent. The one in yellow, it get like multiple hypoglycemia because of increased variability, while the one in green, it is toward the flat line with lower risk of hypoglycemia. And both of them, they give the same hemoglobin A1C. So the today glucose control aim to optimize A1C, so it's time in range, but we need also to minimize the hypoglycemia time in hypo. So there was an urgent need to something called CGM, which is continuous glucose monitoring. So with continuous glucose monitoring devices, we measure the glucose content in the interstitial fluid. So there are two types of CGM devices. There is a real-time device where the CGM device transmit the glucose value every 5 minutes, and there is intermittent scan device like Flash or Freestyle Libre, which measure the glucose every 15 minutes. So we could get a lot of data from the CGM record. We could get the estimated hemoglobin A1C, average blood sugar, and what is the trend of blood sugar, the interquartile blood sugar in like 25 to 75%, or between 10 to 90%, percentage of time in range, percentage of or average glucose with hypoglycemia. There is a lot of data which can be used or can be taken from CGM, but unfortunately they are really very expensive devices. So by this one, I will conclude my presentation that diabetes is a chronic disease which has a devastating complication and require meticulous monitoring. Hemoglobin A1C correlate with diabetes complication, which make it a good tool in diabetes management. The new technology like CGM are promising tools which might be part of the standard of medical care and diabetes mellitus management later on once it get like cheaper. And thank you very much for listening.
Thank you, Dr. Abdul. Thank you, Doctor. It's very nice presentation. Unfortunately, we cannot receive any question at the moment. We'll be moving all the questions to the end of our webinar. Our next topic will be the experience with the hemoglobin A1C. Will be presented by Mr. Ayman Al-Hayek. Mr. Ayman is the head of the Diabetes Education and Insulin Pump Unit, Department of the Endocrinology and Diabetes, in the Diabetes Treatment Center, Prince Sultan Military Medical City, Riyadh. Go ahead, Mr. Ayman. Thank you.
Okay, Assalamu alaikum. Hello, everyone. Thank you, Dr. Saeed, for the introduction, and thank you, Dr. Abdul Ghani, for this very informative and beneficial topic. A big thanks for the Saudi Society for Clinical Chemistry for hosting and organizing such very important webinar during these pandemic times, and to give us, all of us, the opportunity to discuss such very important topic. Okay. Actually, I have been asked, to present our local experience in our hospital, Prince Sultan Military Medical City in Riyadh, Saudi Arabia, as a major tertiary hospital, about our local experience of implementation of point-of-care testing as closer and to the site of the patient care. Diabetes mellitus, as all of you know, that it is a major challenge in the Kingdom of Saudi Arabia, and it is, recently looming a diabetes disaster. And as per, the International Diabetes Federation and as per the World Health Organization, they have been ranked Saudi Arabia as the second highest prevalence and rate of patients with diabetes in the Middle East, and the seventh highest prevalence of diabetes worldwide. And the estimated number of patients suffering from this disease is around 7 million, and more than 3 million patients or subjects they are with a pre-diabetes stage. And if you are looking to the future prediction of diabetes mellitus as a major challenge to the healthcare system in Saudi Arabia, as all of you know that in 2004, Nusa and his colleagues, they have, gave the prevalence of diabetes in the national study, in the largest, national study in Saudi Arabia. They have, gave a prevalence of diabetes with more than 23%. While this number and the prevalence of diabetes, it's almost 10 times increased as per, the prospective future prediction of diabetes mellitus literatures, and we are expecting to have more than 45% the prevalence by 2030. So we are expecting a major challenge and a major increase in the prevalence of diabetes in the Kingdom of Saudi Arabia. Now, moving from the country profile about the major challenge of diabetes to the magnitude of the diabetes in our hospital, Prince Sultan Medical City, since we are talking about our local experience. According to the, to our statistics and census that we have around 35,000 registered medical record number who are suffering from diabetes mellitus, including patients with type 1 and type 2 diabetes. They have a regular follow-up with our, department in our major tertiary hospital. And we have implemented earlier in 2014, we have implemented an interdisciplinary, multidisciplinary patient care and diabetes, services, including all the healthcare, personnel involved in the diabetes care and education, including diabetes endocrinologists, diabetologists and diabetes educators, podiatrists, social workers, psychologists, and dietitians. And what we have noticed since we have implemented this multidisciplinary and interdisciplinary patient and family diabetes education and care, we have noticed that there is a notable and a massive increase in the number of the patients. They have a regular visits to the diabetes treatment center and to the diabetes and endocrine department. And just for the year, just the statistics and the census for 1 year, 2020, that we have, registered an official appointment for more than 13,000 registered as per medical record number. They have a regular visits and follow up with our diabetes doctors, endocrine doctors, and the paramedics involved in the diabetes care and education. Apart from the outpatient visits that our team in our hospital, that we are providing even consultations for the patients who are hospitalized and admitted for diabetes and for any other issues, to the hospital. And also we have noticed since 2017 till the year of 2020 that we have, facing a massive and notable increase of the patients who've been referred to our diabetes doctors and to our paramedics. And we have more than 2,000 consultations registered as per medical record number for the year of 2020. And the standard of care, as mentioned by Dr. Saeed, that the standard of care and everything should be given, and provided to our patients, including the diagnosis, management, instructions, everything. It will be given based on the HbA1c, and the HbA1c considered since earlier, 1970 as a standard of care, and it had been, emphasized this role for management and for the titration and for preventing of the diabetes-related complication by the landmark studies, including the DCCT and UKBTs. And you know, the frequency, even not only the testing and the results, but even the frequency for testing and to be taken as you know, as a reference for any treatment modification or adjustment, or even for the instruction. It's you know, everything it will be given based on the HbA1c, and the better adherence for these guidelines in terms of the frequency of testing. It will be it was, you know, addressed and proven that it was associated with a better glycemic control, improving, you know, the quality of life, and to reduce the diabetes-related complication for patients suffering from diabetes mellitus. How frequent the patient with diabetes they should test, you know, their HbA1c annually? You know, since 2013, there is, you know, standards of care for the American Diabetes Association. They are recommending, you know, the patient with diabetes at least to test 2 times in a year if they are meeting the good glycemic control and if they have a stable glycemic control. While they are requesting at least, you know, for the patients who are not meeting, you know, the glycemic goals as per recommended by the guidelines and as per the primary treated physician, to be tested at least, you know, 3 times in a year. And even in 2015, they start to stressed for the point of care testing for HbA1c. So in general, you know, and in average, the frequency for HbA1c testing should be done three in a year for the patients who are not meeting the glycemic, you know, targets. And looking to the to our situation for our patients, and these slides have been, you know, tracked from the national and local studies. All of them are recent. Unfortunately, that the majority of our patients, you know, including type 1 and type 2, unfortunately, they are uncontrolled. So they are meeting the criteria. They should at least be tested 3 times at least in a year for their HbA1c levels. Even in the Western countries and in our region, in particular Saudi Arabia, the compliance for recommendation to be tested 3 times in a year or 2 times in a year, it has been, you know, there is a very poor compliance, and it's all, you know, only shown the compliance rate for the HbA1c testing. It's around 3% of patients, they are, you know, tested their blood for their HbA1c levels during their visits to their primary treated physician. This poor compliance and adherence to the guidelines and to the instructions for the frequency of the HbA1c, it is proven that it's associated with the deteriorated diabetes control and having more, you know, diabetes-related complication in the future, including the macro and microvascular diabetes-related complication. And then since 2013, there is a stress from the American Diabetes Association for the need of having HbA1c testing analyzers at point of care in the clinical area. And it makes a difference, as being endorsed and produced by many, you know, published data. In our hospital, Prince Sultan Medical City, the vision for the point of care testing and for the implementation and the action to take and implementation of the HbA1c testing in all, you know, clinical areas with the higher demands of patients with diabetes in our hospital, it was based on and made to facilitate an immediate medical decision, and therefore it will improve the patient outcomes, including glycemic control, less diabetes-related complication, and improve the patient satisfaction and reduce the diabetes-related distress due to diabetes mellitus. For proper action, the planning have been, you know, taken in consideration that the patients in our hospital, we have identified the 3 major sites to be implemented for the point of care testing, including the Diabetes Treatment Center, which included the endocrine and diabetes department, primary health care, and to cover the pediatric diabetes population in the pediatric diabetes clinic. The evidence for this quality improvement project and to have the point of care testing in our hospital, as I said, it's to have, you know, because many recommendations and many studies and published data, they have, you know, emphasized the role of the point of care testing if it's implemented in all the clinical areas, shown to facilitate the diabetes management and improving the communication and the adherence from the patient perspective. Our experience before we implementing the point of care testing, as I think everybody is facing the same issue in diabetes management, that the patient, he will come to the hospital with an official appointment with his doctor. His doctor, he will request the HbA1c testing. This HbA1c, it will be done based on the traditional laboratory testing. It's require additional visit to the lab. Additional visit to the lab, it's required, absence from the work or absence from or excuse from the school, additional cost, and maybe most of the patient, and very seldom, and very small number of the patient, they will come to test, frequently as per requested from their healthcare provider. So the laboratory HbA1c as a traditional, it has one potential disadvantage, that it might be not available at the time of the patient visit due to the turnaround time, which required, for testing and reporting and to be ready during their visit to their primary treated physician. If this result is not ready, the doctor, or maybe there is a delay in the result, then the doctor, he will, and the healthcare provider may, delay the modification, and sometimes, there is no instruction will be given to the patient. And this delaying in the communication for the result, for the HbA1c result, it will delay the intensification or modification for the treatment. This will be, it has an impact on the patient adherence to their treatment plan. Sometimes having an additional visits and multiple visits to the hospital to do the pre-visit HbA1c testing, sometimes it must be taken, 3 days or 5 days prior the visit, the official visit to the doctor, and can be inconvenient to the patient, since it has, and require extra time and effort and cost and traveling for the second visit. And not only, the patient, they have an official appointment with their doctors. Also, we see the patients who came as a walk-in. They need, a ready HbA1c test, which is not ready. So it will delay the communication with and intensification or modification for the treatment and management plan. So and also what we have noticed in 2015 as example, that we have noticed a huge number of our patients who are coming to our department, endocrine diabetes department. They are visiting, our center, and they have a consultation with our doctor, even without having a laboratory, fresh laboratory HbA1c, because they are not having visited the laboratory as per instructed by their healthcare provider. And we are looking for, a supportive tool, but what we are looking for is to have a POCT for HbA1c that require a minimal training from the healthcare personnel, including nurses or diabetes educators, that they can do this HbA1c based on the general competency or just very minimal, training requirement from the healthcare personnel. So what we are looking just to do an action plan. This action plan that have been designed in Prince Sultan Medical City, it was based on 3 major cornerstone and factors: having something which is rapid for the point of care and to have an immediate results, and as well as just to save, and to reduce the direct and indirect cost for the point of care by reducing the benefit, by increasing the benefit of using the point of care, at the same time reducing the waiting list for the patients who are having, their appointment with the outpatient clinic, as well as reducing the length of stay for our patients who are hospitalized. The major factor that we were looking for is to improve the communication, because and the dialogue between the healthcare provider and between the patient as face-to-face, because the rapid availability of the results for glycated hemoglobin, it will allow a proper discussion and communication, and it has, will improve the patient and doctor and healthcare provider dialogue and patient satisfaction. It will it has an impact on the improvement of the adherence and compliance from the patient to their management plan, and at the end of the day, it will improve their glycemic control and reduce the future diabetes related complication. Everything in 2018, it was ready, action plan. We have identified our aims, and we have, identified everything so that we were ready to go to implement, the point of care testing in our hospital, and was led by the Central Military Laboratory and Blood Bank. And it was introduced in 2018, earlier 2018. And as I said, we have identified the three main areas with the higher demands of the patients with diabetes, including the outpatient clinics, including pediatric diabetes, adult endocrinology and diabetes, and the primary healthcare as a major, sites with the higher demands of patients with diabetes in our major tertiary hospital. As a part of our, local experience, that we have to have a validation process for any items going to be introduced to our hospital, and to have more evidence about the validity of the point of care testing device. There is a local experience and validation experience done by the Department of Central Laboratory and Blood Bank in our hospital. And in this study and local experience, they were evaluated as 6 POCT HbA1c analyzer in our hospital. And the main objective of this local experience study, it was to evaluate the performance of 6 Roche Cobas P101 with respect to the precision, accuracy, linearity, with the reference to the lab, to the traditional lab Cobas C513. And we evaluated in our hospital these 6 devices compared to the lab one. The methodology, as I said, it was done by the central lab based on the precision, accuracy, linearity compared with the venous sample to the POCT results. In this study, a venous sample were run to each analyzer and were compared to the laboratory reference method. And the results, it showed that a satisfactory, precision, linearity, and accuracy compared to the laboratory analyzer values. And at the end of this study and local experience, the investigator, they shown and they presented that overall performance of the POCT device were acceptable, and it is reliable and can be implemented in our hospitals as a supportive, and alternative method for testing of patients with diabetes for their HbA1c testing as a near or close to the site of care. Based on the recommendation and based on the, on the results of this validation study, that there is a memo and there is a guidelines from the higher administration to implement the point of care testing device for patients with diabetes who have regular visits with their doctors in the 3 main identified areas, including the pediatric, adult, and the primary healthcare facility. So, many studies have shown that it will improve the glycemic control. It will reduce the direct and the indirect cost for using and implementation the point of care testing, and it will reduce the turnaround time. And it will facilitate any medical decision and improve the clinical operation. But however, if you are looking to the literature, that you will find very little published data concerning if the patient are satisfied or not satisfied, and what's the satisfaction and the perceived satisfaction from the patient, perspective about using and implementation of the point of care testing in the clinical area. Why? Because most of the patients, they are not visiting the hospital and the traditional lab to do the point of care testing because of the cost, turnaround time, and the extra time and efforts they need to do the point of care testing in the lab. So there is a patient perceived outcomes and factors that have interfered with their doing the HbA1c testing in the laboratory. So what we have, we have developed a quality improvement project, and we have, in our hospitals that we try to assess. It's not, as a local experience, it was as an quality improvement project in our hospital to assess what the healthcare provider perceptions and the benefits of future use and implementation of point of care testing in the clinical areas within our major tertiary hospital. We have developed and we have distributed this survey. And this survey we used to give to all of our patients who are accepting to do the HbA1c testing and as a point of care in our diabetes and endocrine department, and this concerning all the aspects from the patient perspective, including if they are happy with the finger prick compared to the because the point of care testing it's based on the finger prick testing. It's not require a needle in their arm. If they are happy about the hygiene that we are providing to do the point of care testing, and if it's improved their dialogue and communication and the trust and confidence with their primary healthcare treated physicians or with their diabetes educator and dietitian, and if it's save their time and efforts to compare to do the traditional laboratory point HbA1c. So we are covering in this survey the most possible and the possible factors from the patient perspective to do the point of care testing as a point of care testing compared to the laboratory one. And we have a preliminary analysis for our results and for the patient responses to the question. What we are expecting, that we have noticed there is a significant improvement in their areas, on all areas and all statements in the questionnaires and the survey that we have given to them, whether they are prepared to have the finger prick compared to the needle in their arm, and mainly for patients with type 1 diabetes and young adolescents and youth patients. And if they are happy with the hygiene that we are providing in the point of care, and whether they are confident about the results of the point of care HbA1c compared to the lab, and not having a visit, another additional visit to the lab if it's convenient or inconvenient for them, and having immediate feedback for their HbA1c testing using the point of care testing, whether it's improve their communication and their condition and their discussion with their physicians, and if they are motivated to do it, and if they are happy to do it and recommending doing the point of care testing in the next visit. So it has a significant impact and improvement, and improvement in their perception and their satisfaction, usability, and acceptability for implementation of the point of care testing device. So what we have addressed in our local experience of implementation of the point of care testing in our hospital, that we have noticed that we have addressed all the healthcare providers and patient as well as patient needs, and it is because simply a requirement of 5 minutes compared to the days and delays, it has an impact on the convenience and acceptability for the patient. There is no training requirement required to do the point of care testing, just a simple general competency. It is enough for our nurses to do this point of care testing, and we got based on the local experience study that have been done by the central lab, and accurate results which can be used as a guidance in our diabetes management and modification, intensification for any management. It significantly improved the patient satisfaction. It has an impact on the cost effectiveness, and at the end of the day, it's improved the diabetes, and the glycemic control, and hopefully that it will reduce the diabetes-related complication among our patients suffering from diabetes mellitus. So in summary, for our local experience with the implementation of the point of care testing in our hospital, that implementation of this, as if it's implemented as near or at the site even of the patient care, it will improve the diabetes management, it will improve the treatment adaptation, and will improve the glycemic control and the patient satisfaction, and improve the cost effectiveness for our hospital and for the kingdom as general. So the take-home message from our local experience with implementation of the point of care testing, it will improve the population health-driven HbA1c testing adherence and compliance. Then we will have no missing HbA1c testing for our patients coming with diabetes to our diabetes department, and this will have more timely intervention of diabetes management for our patient with worsening disease. And during this pandemic times, especially during the COVID-19 era, that there is, as all of you know, that visiting restriction even for the intra-hospital transmission for our patients. So having the on-site point of care testing, it will minimize, you know, the intra-hospital transmission and transfer of the patients, and it will reduce, you know, and minimize, you know, the COVID-19 transmission even during the same hospital or the same institution. Here I have done my presentation, and I would love to hear if there is any feedback or comments. Thank you all.
Thank you very much, Mr. Ayman, for these fantastic presentations.
Thank you.
Our next topic will be the point of care testing quality review, and will be presented by Mr. Muhammad Al-Shiridi. Mr. Muhammad has he is the quality manager in Roche Diagnostics. Muhammad has started his career as medical lab scientist for 5 years in the regional accredited private lab. Mr. Muhammad now is responsible, and his team in Roche, to provide quality support and consultation to the hospital and the laboratory to achieve quality best practice, international accreditation, and ensure patient safety. Thank you, Mr. Muhammad.
Thank you, Dr. Saeed, for the introduction, and thank you as well, Dr. Abdul Ghani and Dr. Ayman, for your fruitful discussion. Let me share my screen, and I hope you can see it. Good evening, everyone, and wassalamu alaikum. Hopefully, I will try to take you for this evening in a quality management overview for point of care testing in general, and maybe at the end we can touch a little bit on the validation for some of the hemoglobin A1C instruments. I believe Mr. Ayman has already touched on it in terms of validation requirements. So we'll try to leave maybe more space for the audience in case you have any questions or any inquiries. So I would say, if we are looking at, so basically we're going to look at the point of care regulatory requirements and the point of care method validations. Now, once we talk about regulatory requirements from our side, especially let's say when we are talking about healthcare professionals, we need to be aware of the international accreditations guidelines, some of the international as well best practices when it comes to point of care testing and also patient testings in general. So hopefully with our objectives for today, we are looking at why the standards for point of care testing is important. We are looking as well what are the main areas of global consensus on how can we manage a safe and effective point of care testing services inside our healthcare facilities. What is the accreditation and why would an organization engage in any accreditation requirements or checklist? And then we can look into what are the common quality weaknesses of a point of care program. And maybe we can mention some of the examples for some of the most KPIs that we have inside our hospitals in general, and also very specific to point of care testing algorithms. So if we look before on what are the let's say what are the needs and what are the requirements that currently or for this time that we have an international standards for point of care, we can check some of those some of the most common challenges that we faced as point of care operators maybe in the past. So you can see that in the past we did not have any point of care policy, or there's no point of care committee and no point of care coordinator established inside the hospitals. Now usually what we see is central labs is partially responsible for point of care in hospital wards, and frequently the point of care devices or testing is not funded. Now, many clinicians are unaware of the consequences of point of care and try to initiate new tests, maybe without the support or guidance of the main labs or the coordination of the quality team. Now, so taking all those consideration in the past, there was a long-standing internationally recognized standards are established that define a level of service quality, mainly targeting the point of care testing inside our hospitals. So some of those global regulatory attention that came, that let's say start focusing more on point of care testing and best practices, starting with the Global Harmonization Task Force, and then we have the Pan-African Harmonization Working Party, and as well the Asian Harmonization Working Party. Now, what we can see as a common across all those task force and parties, all express strong desire for global accreditation standards to improve point of care quality and service delivery. So it becomes rather than a minor section inside our accreditation checklist and our hospitals, and improved to something extremely important. And we have a global and regulatory standards dedicated for best practices inside point of care. Now, just to mention that all those organizations are supported by the Gates Foundation, who are also becoming increasingly involved in the point of care testings, and the ultimate goal of bringing the testing, the patient testing, closer to the patients and the patient centricity concept. Now, when we see the point of care regulatory requirements, I guess we are all familiar with most of the accreditations that we have in our region, starting from the CAP, JCI, ISO, and also when we are looking at local accreditation bodies such as the SIBAHI inside Saudi. Now, if we want to have a quick look on, let's say, if we want to see the US market or the US regulations, and taking CLIA, for example, as one of the most famous regulatory bodies, we know that we have three regulators for CLIA. Those are the CDC, FDA, and also as well the CMS. Now, looking at the CMS, for example, or the Centers of Medicare Services, basically those bodies conduct inspections and enforce regulatory compliance, and also issue lab certificates. Now, if we are looking at the FDA, on the other hand, FDA, as we all know, they are responsible for the test complexity categorizations. And maybe later in a few more slides, we're going to look at the categorizations of the test between waived and non-waived, and how does that impact the lab personnel, and also how does it impact on the patient safety from the other side. Now, if under the CLIA or the CLIA regulatory bodies, we can see different accreditation bodies that they are already accredited inside under the CLIA umbrella. And that's, of course, the College of American Pathologists, or CAP. We have the JCI, and as well we have the American Association of Blood Bank group. Now, what's always tricky when it comes to accreditation requirements is those accreditation organizations mostly provide us with a checklist, the what part which is required from labs and hospitals. However, maybe they are not providing us with an exact how to establish or to fulfill a certain requirements inside the accreditation checklist. And at this point, we can refer back to the prestigious CLSI guidelines, and we can take also as well the quality best practices to fulfill those accreditation checklists and requirements. Now, this is what we talked about. We said that FDA are mainly responsible with CLIA on the test complexity classifications. Now, why do we need to know that as lab staff professional? Now, from our side, let's say we need to identify our devices if this is waived or non-waived, because based on the classifications, the validation requirements and the method verification specifications will be different. So basically, when we talk about waived, we are looking at a less complex device without a major impact on patient safety. Patients can operate or can use the device by themselves. And this is basically like the old generation from the AccuCheck testing for blood glucose. It's waived, patient can use it. It's not a high complexity, without and critical impact on patients. On the other hand, when we are looking at for any non-waved instruments, so now we are looking at more complicated devices. Depends on a more complicated methodologies and techniques. It's only can be operated by lab professionals trained and certified, and as well the results or the impact of the outcome for those devices has a direct impact on patient safety. Now, maybe going away a little bit from the US umbrella and the CLIA, we all know also as well the ISO and accreditation standards, and mainly driven by the 15189. It's dedicated mainly for the medical labs accreditation standards. Now, if we're looking at, let's say, again, in the same concept, those accreditation requirements, UCAS or the ANZ or other international bodies, we don't have specific requirements when it comes to how to operate in certain quality aspects, and also what is the validation requirements for our point-of-care devices. And again, it will take us to the need for unified international guidelines, for example, the CLSI guidelines. Now, if we're looking, if we have a better look, let's say, on some of those accreditation requirements, and I highly recommend you that you need at least to have a copy of those international standards, or to maintain or to try to get a copy of those guidelines inside your lab for any point of care testing unit inside a hospital. So basically, we're looking at the ISO 22870. This is it's giving you the fundamental requirements for quality and competencies for the point of care committee and operators. When we are looking at the when we are looking at the CLSI guidelines, we have 04, we have 09 guidelines as well that address the main challenges for point of care testing inside any lab. Plus the point of care testing checklist for CAP, which is a bit more detailed than ISO. Giving you a bit more hands-on of what is required and probably how to achieve some of those requirements. Okay, this is what we talked about, let's say, in a brief about the ISO requirements for different standards. Now, looking at the CLSI guidelines, and those I would say can be considered as the backbone for your validation and for your quality requirements. So looking at the point of care 04, and looking at the point of care 09, those can be the main two guidance inside your hospitals, inside your lab for point of care management. Especially when we are looking at point of care 09 guideline, talking about selection criteria of point of care devices inside your hospital. Because we always look at different parameters to keep in mind whenever we want to choose a point of care device. And let's say we are also looking at the point of care glucose testing in acute and chronic care facilities, and this is as well an approved guidelines, point of care 12A3. This is a dedicated guideline from CLSI regarding the glucose testing inside the hospitals and the chronic care facilities. And the list, let's say, the list goes on in terms of what is needed inside our point of care unit to make sure we have a proper or we have a complete quality management as well as a risk management approach inside our point of care testing. Okay, so now if we are looking at the most or the global consensus over the use of point of care and why, or let's say what are the main drivers and challenges that we have across different countries. Now, in most countries, there are no regulations that prevent the use of point of care. So that's something that's an advantage for hospitals and advantage in case of healthcare providers. The main barrier to the widespread use of point of care is related to funding. We can understand that maybe from a cost point of view, it is more cost efficient to have one centralized testing unit inside our main lab, which will save us the multiple devices inside our hospitals. However, this will come on an expense of turnaround time, troubleshootings, breakdowns, and also sample transportations and logistics, where point of care device can provide different solutions to overcome those challenges. In many countries where healthcare funding is provided by government or by a private health insurer, some form of regulation is required which govern the way which point of care may be implemented. And we can see maybe some of those regulations will start to emerge and start to increase in the upcoming years inside our region, inside the Middle East as well. Now, if we looked at the let's say some of the common elements in most countries when it comes for the need for point of care testings, basically it's a fit for purpose when we're looking for the point of care objectives or goal. Quality testing is being provided and maintained. So those, let's say we can say that this is our checklist to maintain a proper quality management for our point of care, and as well as let's say our best practices to ensure our patient safety. We are looking at device operators have the required skills and competencies. We are looking at the appropriate maintenance, and we have a proper maintenance log and schedule for all our devices. Devices comply with defined technical specifications. We are aware of the device specifications, and we are meeting, or let's say we are choosing and selecting our point of care devices according to the specifications intended for each hospital. Testing is provided in a safe environment, provides a consistent base for all testing procedures, and provide as well some consistency between multiple service provider, because at the end our patients can be at different hospitals, different sites, where we need to ensure that we always reproduce the same results to maintain a proper treatment and follow-up pathway. Ensure that patient records are managed in an appropriate and consistent manner. When it comes to record management, maybe later on, we will see that one of the most common findings or deficiencies cited by CAP is document control and records management. Inhibit uncontrolled and inappropriate use of testings, and also provide a mechanism for assessing the distribution of valuable healthcare spending. Now, so this is what we said in terms now of accreditation. The accreditation, as we all know, is an assessment by an external body, hopefully to provide us or to ensure that we have a proper quality management in place to guarantee patient safety at the end. Now, if we are looking at the general benefits for any accreditations, by having this independent confirmation of accreditation specific for point of care section inside your hospital, point of care providers can reassure users of their services. It's a certificate of good quality, and it's a certificate of approved patient safety provided by an international independent party. Users and managers of point of care should contact their national accreditation bodies directly. Always keep your communication channel open with them in case you faced any inquiries, any issues. If the manufacturer, first of all, you have the manufacturer always to support you, and the second is to keep your communication channel with your accreditation bodies open. This international consensus is a good reference for all hospitals considering or running a point of care services, because at the end they are all operating under the same core principle, which is the patient safety. Now, so what's the benefit when we are looking at the point of care accreditations if we want to have a bit more specific look on this? So now, the accreditation acknowledge a level of organizational competencies inside the organization. It also identifies area in need of improvement and provides suggestions on how those improvements could be made. The idea of any accreditation or any inspection is not to highlight flaws or gaps or defects. It's basically an area of improvement that will help the hospital and the facilities at the end of their journey to maintain a high quality standards and operation inside their facilities. Accreditation requires that an organization have numerous management controls in place related to accountability and efficient, effective use of available resources inside the hospital. Now, from a patient point of view, if we are looking at from a patient perspectives, I would say as a patient, I will always be able to expect the same level of service quality across different branches and different, let's say, province for any accredited sites or programs. I can be confident that there are appropriate protections in place for privacy, staff competency, and supervision, handling of complaints, and physical safety aspects. As well as a patient, I will know there is a quality improvement process in place to continually improve services, and as well know there is an opportunity to have input into service generally as part of consumer-based planning processes or as customer feedback processes. So let's say the patient in our equation is a main driver when it comes to point of care, and it's extremely important always to get the feedback from their side. How can we improve our processes, and how can we maintain a risk-free process towards our patients? Now, if we are looking at the hospital as well, the hospital will have a confidence that the organization is providing good services and has built-in mechanism to ensure it's continually working to improve the services, opportunity to improve validation of the work inside the organization, as well as improve culture inside the organization to improve itself and staff and practices. The staff of the organization will have a sense of achievement, a sense of let's say a proper quality management in place when you achieve your accreditation on a long run. Now, when we look at some of the common, let's say, weaknesses, or let's say some of the areas that we can implement our KPIs inside our labs, because we'll always have a place for improvement inside our lab. So first of all, we need to make sure we don't have any patient results are not reported. If your QC, if your quality control is out of range, you can check whenever your QC is out of range. For example, from your records, did you release any patient results during that time? You can have an additional KPI that your QC is performed by the same individuals who are performing the tests. Now, unfortunately, sometimes we might have some mispractices that that our lab personnel are controlling the point of care quality practices, while the nurses or other healthcare professionals inside the hospitals are doing the regular patient testings. And this is one of the important gaps that we need to address and to close it between main labs and also the operators of point of care devices. Corrective action are implemented and recorded inside our hospitals. Patient results are reported with reference ranges, and as well as our maintenance check and function checks are always performed and documented according to our scheduled intervals. We need to make sure that those devices are very delicate and very sensitive, and we need to give it an extra careful and attention in terms of maintenance to guarantee our patient safety for testing. Now, one of the important points I would like to highlight is the proficiency testing sample is rotated among all testing personnel, and this is, I would say, some of the gaps that we identified in the region is when we have point of care devices. So usually the main lab will be responsible for proficiency testing to run the samples and also to report it or to implement any corrective actions. However, the patient samples testing is being done by the nurses, let's say, or different healthcare professionals inside the hospital. And at this point, when you divide your proficiency testing for the main labs responsible for it, while the patient testing is being done by a different group inside your health organization, you are creating a gap, and you are not getting the full benefits of your proficiency testing from the service provider. Supervisory review of QC maintenance and patient results. We know that now currently we have several IT solutions when it comes to point of care quality management. It's giving you a state of the art in terms of controlling and proactively anticipating any failures or any QC failures for your point of care devices. If you can implement it inside your hospital, I highly recommend you to implement it. If not, you can still do it. We can still monitor and we can still control our practices, our quality practices, and also troubleshootings in different tools and resources. Ongoing training and competency program, and this is what we said. It's one of the important findings that we have, or citations that we have identified inside CAP. So, for example, Looking at the commonly cited point of care deficiencies, the main one is the competency. Now, unfortunately, the point of care device, by its nature, it's easy to use, very friendly, and it's basically plug and play. However, we are taking advantage of those features in the point of care devices without having a proper competency trainings, records, inspection, supervising for our point of care devices operator. So we need to make sure, or we need to ensure that our operators, our point of care operators, are competent with the proper training certificates, proper training records as well, to be presented whenever is needed. Activity menu. Now, unfortunately, what's happening is most of the times when you have, I would say, when you have, again, because the nature of the point of care device, it's an easy use. You can always introduce new tests inside your hospitals based on the physicians and the lab requirements. However, we can't miss adding the list of tests and the activity menu inside our policies and procedures for inside the hospitals. And the third one, if we're looking at the document control, this is what we talked as well before, the competency of records for our staff, activity menu, documentations, QC out of range, corrective actions, maintenance logs, rotation of our medical point of care devices within inside your hospital. Those are all related to documents control and document management inside our facilities. Now, so maybe as a summary before we jump to the second topic is, if we are looking at our guide for a quality point of care program. So first of all, have the right supports in place for your point of care. The organization defines who is responsible for point of care. The organization has the necessary resources to deliver high quality for the point of care program. Make sure people are competent. Healthcare professionals delivering point of care are trained and certified, and make sure always to maintain your records and your certificates for your healthcare professionals. Comply with good laboratory practices. Follow point of care standard operating procedures. Use your point of care equipment safely, and also monitor your point of care supplies, reagents, and media. Delivering safe and effective point of care. Healthcare professionals delivering point of care safely and effectively carry out the tests. The organization accurately and securely reports point of care results. As we said, make sure you have the reporting range with each point of care results. And maybe in addition, you are also reporting, or you're adding as well, the point of care users on the report. And this is for tracking and quality control process. Monitor quality and achieve positive outcome. The organization regularly monitors and improve the quality of point of care testing inside their facilities. Now, I would love to touch a little bit on the validation overview, a little bit of the aspects that when it comes for a point of care validations. What might be a bit tricky for us is when we're looking at sample types, we are looking at the availability of samples, and we're looking at some technical or specifications regarding our point of care device in general inside our lab. Now, what's important for us is the main elements when we talk about any method validations. And if you remember, as a start, we need to identify our device, if this is waved or it's a non-waved device. If your device is a non-waved, it means it's a high complicated device with let's say with more accurate and more precise results for your patients. Looking at the non-wave device, we are looking at we are compromising a little bit on the accuracy and on the precision part. Now, if we ask ourselves as well, should all our point of care devices results correlate with the main labs? Should it match or should it correlate? And here it's always a debatable point. In general, we would say for point of care devices, we are expecting our point of care results to correlate with our main lab. So our point of care results, it may not match, but it should always correlate with our main lab. Now, if we took it a bit more specific towards the hemoglobin A1C, and as mentioned by the previous speakers, is there is a more tendency in terms of hemoglobin A1C standardizations, which will make sure that we have the same results and the same clinical outcomes when we are looking at different methodologies and devices. So, for example, let's say if we can skip this point now. So, as we said, for hemoglobin A1C as a start, we have to check our accuracy for our devices, and here we always recommend to use a 20 samples covering your AMR or your analytical measuring range. Now, for hemoglobin A1C, now we are taking the advantage of that most of the methods for hemoglobin A1C are standardized, especially with the National Glycohemoglobin Standardization Program and also the ICC. So we can run our accuracy check in more confidence and more, let's say, in more smooth process, comparing our point of care device with our main lab and looking that our results will correlate and as well will match because of this standardizations. Now, usually we always recommend to use a double acceptance criteria, and this is the plus minus 0.5 from the actual percentage, or as 6% when we are looking at high concentration discrepancies. Now, when we are looking at precision, now in terms to verify your precision, as we always recommend to follow the CLSI EP15 guidelines, and this is the 5x5 procedures, 5 replicates per day across 5 days. However, when we are looking at point of care device, you might change it as long as it's mentioned and explained inside your policies, method verification procedures. And I would say maybe the last one, which might be a bit more challenging for most of us, is the AMR verifications, where we have to verify the linearity and the linearity of our measuring range for the devices. At this point, you might have two options. The first option is to go for your commercial materials, material already available that you can use to verify your AMR range. And your second option is to use a manual procedures where you have 3 to 5 points inside your AMR, covering your AMR as much as possible. We always recommend to measure each sample or each concentration point in duplicate to avoid any possibility for random error. And then you are looking for your best fit line analysis for those 3 to 5 points. I would say maybe the one of the challenging points as well, it's always will be the sample type, because when we're looking at point of care devices, sometimes we have a capillary sample type, while the main lab is looking at venous blood draw, logistics, transportation of samples, storage of samples, as well as the challenging concentrations. And with just to add maybe one last point to this topic, is always try to make sure to identify your clinical decision values. Those values which is important for you, because you want your accuracy, you want your precision, and you want your verified AMR always to tackle and to cover those clinical decision values, that based on those values, your physicians and your patients can decide, for example, if we need to increase or decrease our dose, we need to hospitalize or send our patient release. So always keep in mind your your clinical decision points inside your verification protocols to make sure that your verification and your testing process is in place to ensure patient safety at the end. I guess that is the end. I hope I did not bother you with too much technicalities on the accreditation and the validation topics. Maybe I will leave more time for your questions and your inquiries. I will stop sharing from my side, Dr. Saeed.
Thank you, Mr. Mohammed, for this informative presentation. I enjoyed it.
Thank you.
Now is the questions time. For all audience, use the chat icon to write your questions. But before that, we're gonna note that this webinar is accredited by 3 hours CMEs. By end of this webinar, will be send a survey to all the attending audience. Fill this survey, write the Saudi Council number, and we're gonna add it to your Saudi Council. Okay, we have a questions here from Victoria. What is the explanation for patient checking the FPS by glucometer give high results, but when the patient do the hemoglobin A1C, the result is normal? Dr. Abdul Majid.
Shall I answer?
Yes.
Okay. The glucocheck machine is like using the capillary blood. So to be accepted by ISO or other society, it is plus minus 20 milligrams. So it's like 1 millimole per liter. You cannot depend on a finger stick glucocheck machine for diagnosis of diabetes. It's a tool which is used for monitoring of blood sugar, and even there is like a marginal accuracy with it. So we should use it with tendency, like a trend. Is it going up or is going down? So you cannot take it for granted. For diagnosis of diabetes, it has to be fasting plasma glucose. So it has to be plasma glucose rather than the finger stick, okay? Hemoglobin A1C is a more stable one. So if it is used according to the NGSP standard or IFCC standard, it's really accurate. It will give you just like, and it's really a stable one rather than the unstable finger stick, or even if she used the fasting plasma glucose. I hope that answer the question. And if there is any comment from my colleagues.
Any more questions, please? I have one for you, Dr. Abdul Ghani. In the hemoglobin variant, we are using the fructose amine. It's like for 2 to 3 weeks. Do you think using the library will be another solution to measure the glucose during the 1 month, for example?
The freestyle library?
Yes.
The freestyle library is a method which used like interstitial fluid to check the blood sugar. To check the blood sugar as like it can be used like a flash or an instant reader. It's not really accurate, okay? And there is a problem with accuracy, especially with the starting with the sensor or toward the end of it. So it's really variable. Fructosamine is like a glycated protein. So it will give the average blood sugar over 2 to 3 weeks. It's also a good tool for monitoring the blood sugar if you cannot use the hemoglobin A1C and hemoglobinopathy. Although the NGSP, using different method of hemoglobin A1C, they got like a schedule where you could see your assay or which company, and will tell you if the hemoglobinopathy is affected or not. Okay, so if I were you, I will prefer to use the hemoglobin A1C still. The fructosamine we were using it previously. It is, the practice is not to be used. Wide range, but it's a good tool once you cannot use the hemoglobin A1C. Libri is a good tool for monitoring the blood sugar. Even the company will tell you if the range is between like below 80 or more than 180, you should just count. You should do just finger stick before doing an action, like if you will give an extra insulin or you will act on hypoglycemia, you might need to do a finger stick of capillary blood sugar. We find it like in many pregnant ladies, there is really a wide range of variability with Libri. And there is a big difference between capillary plus Libri. So I think there is a limitation with each one. You could use it as a trend, and I think with the trend it's really excellent. It gives an estimate, but you cannot use it for diagnosis or for granted changing the management.
Okay, thank you, Doctor. There is a question from Mr. Majid. Say, if there is any approved reference range for the pediatric regarding hemoglobin A1C or fasting blood sugar.
So the criteria for pediatric for diagnosis is the same. So this is the American Diabetes Association. So they use the criteria of fasting blood sugar of 126, which is 7 millimole, and it has to be 8-hour fast with no calorie, or the one who's having blood sugar more than 200 or 11 millimole with symptoms of polyuria or polydipsia, which is symptoms of hyperglycemia, or using the 75-gram oral GTT, whether if you get like an abnormal fasting more than 126 or the 2-hour post oral GTT more than 200. Regarding the hemoglobin A1C, the problem, you could use the hemoglobin A1C in type 2, but you cannot use it for diagnosis in type 1. And most of pediatric group, they are type 1 diabetes. So I will refrain from using the hemoglobin A1C as a tool for diagnosis, but we are seeing a lot of patients with type 2 diabetes because of increasing obesity in pediatric. So if it is type 2, you could use it as a tool if you get the proper standardized method in hemoglobin A1C. Otherwise, it is the same criteria.
Thank you, Doctor. Other one, he said, how many type of C peptide are there, and what is their implications?
So C peptide is the precursor of insulin. So we use it to indicate if the patient is getting endogenous insulin or not. So if there is no C peptide, that means either the patient is insulin deficient or he's type 1, he get like an autoimmune diabetes with destruction of beta cell. The one who's getting high C peptide is mainly toward the insulin resistant, they are toward type 2 diabetes.
Thank you. Mr. Ayman, I think this is a comment saying carbohydrate-free diet and its role in the management of both types of diabetes.
You mean if it has an impact on the improvement of the glycemic control? Yeah, it's shown. There is many studies that shown that a low carbohydrate and the balanced diet, in terms of the balanced diet for patients with diabetes or without diabetes or pre-diabetes, it has an impact on the improvement of their glycemic control, especially for patients with type 1 diabetes. You know, when they are matching their carbohydrate to their insulin doses, it has a significant impact on improving for their glycemic control. For patients with type 2 diabetes and those who are treated with insulin, low carbohydrate diet, it has an impact if it's balanced with the with the low glycemic index and high glycemic index carbohydrates. So it has an impact. I have just one comment regarding the estimated HbA1c as gained by the intermittent scanning, for flash glucose monitoring or any other CGM. Nowadays there is many studies, they are comparing the estimated HbA1c for the Freestyle Libre users or any CGM, real-time CGM. It's almost, there is no significant difference for the regular users for the flash glucose monitoring systems compared to the lab, based on the estimated HbA1c levels derived from the device or from the ambulatory glucose monitoring profile for any patient who are frequent users and regular user for the flash or for any type of the real-time CGMs. It's almost the same one that you can get from the lab. So for the modification, intensification, treatment, management, you can rely on it based on the latest publication. But for the diagnosis or for for taking any action, immediate action for any insulin correction dose or whatever, that even as per recommended by the manufacturer, that you cannot rely on it. And I do agree with Dr. Abdul Ghani, just you can use it for a trend. But even for the, if you ask about the estimated HbA1c, even from our experience, it show almost at match with the laboratory and point of care testing one. Maybe you can find a difference of 0.1 to 0.2, which is matched with the international published data. But in general, the estimated HbA1c determined by the any real time or an intermittent flash glucose monitoring system, ambulatory glucose profile, it's almost the same.
There is Emily asking, say, between the fasting blood sugar and postprandial blood sugar, what is the more diagnosis test for diabetes?
So you can use any one of the 4 diagnostic criteria. I think people now toward using the hemoglobin A1c because it's more convenient and more stable. But just we should stress also, if you use the hemoglobin A1c for diagnosis, please check the reliability of the assay. It has to be in GSP. It's really important. But whatever method which is used, the most stable one is the hemoglobin A1c. But she could use the fasting blood sugar, the gold standard doing the 75 gram oral GTT. So she will do the fasting blood sugar plus 2 hour post 75 gram oral GTT. Or the random blood sugar if there is symptoms of hyperglycemia. Otherwise, the most convenient one is the hemoglobin A1c. And now they recommend doing 2 tests. So she could do the 8-hour fast with no calorie plus hemoglobin A1c, and if both correlate with each other, the accuracy almost 100%.
Nazik also is asking, what about herbal treatment? Is there any study approved the USA for it?
Herbal treatment, there are so many herbal treatment for diabetes. We cannot say anything regarding the herbal treatment here because this is beyond our beyond the presentation here, all the 3 presentation. And if you use any herbal, please just be sure it is safe and there is enough study on it, because there are some herbal which are toxic and might be harmful.
Okay, Mr. Ayman, there is inquiry came. He said, like, I want to inquire about the low carbohydrate regime. Does it work for the patient?
It should be. There is no low carbohydrate. There is, nowadays there is, a trend. They call it, a balanced diet to avoid the high protein and high, fat diet, and avoid, even the extreme low carbohydrate diet for patients with diabetes, because it has a side effects. The dose of insulin for the patients treated with insulin, especially for type 1 diabetic, it should match with their carbohydrate diet. They cannot, go to the extreme. It should be balanced and should be calculated, and to be matched with their insulin dose. But going to the extreme with the carbohydrate, it has even a side effects for a patient. And many patients, they are reporting nowadays, the diabulimia, and they are, omitting their doses because they are considering their insulin doses, because they are considering they are not taking, a carbohydrate at all.
Thank you. There is no more question from the audience. I have last one for Mr. Muhammad. We know that the validation is important for point of care testing, but also I think integration, it's much, also we need it. It's high needed. What about now point of care, hemoglobin point of care for integration? It's already integrated with any LI system or not yet?
Yes, well, thank you for this this important point, especially now because let's say most of the diagnostic area is moving into more integration and more into artificial intelligence. I would say now most of the IT solutions already provides an option to integrate point of care devices as well as the hemoglobin A1C. and this is to ensure a centralized quality management when it comes to the different point-of-care devices inside the lab. Because one of the challenges, again, it depends on the nature for the point-of-care device, is you will have around maybe 30 or 40 point-of-care device distributed inside your hospital. And to ensure or to make sure that you have a proper patient testings, a proper quality control in place, it's always important to use and to leverage your IT solutions and the connectivity with the LIS. So yeah, it is an important point to be integrated. It's feasible. Several IT solutions there in the market are giving you this option. So I would highly recommend it to be used inside the lab. Thank you.
Now we came to the end of our presentation today. In behalf of the Saudi Society of Clinical Chemistry and Point of Care Testing Associations, I would like to thank Dr. Abdul Ghani and Mr. Ayman and Mr. Muhammad for this informative presentation and talk. Thank you for all the audience and attendance, and have a lovely night.
Thank you.
Thank you very much.
Thank you, Dr. Said. Thank you, everyone.
Thank you. Thank you.